Back and welcome to our session on access to surgery. Again, we have an outstanding lineup of panelists that include Dr. Asima Mukhopadhyay, who is a gynecological oncologist in the UK, but also works at a specialist unit in India. Professor Andreas DuBois, who is Professor of Gynecological Oncology at Kliniken, Essen, MD in Germany. Charo, who is the president of the Spanish Ovarian Cancer Patient Advocacy Group, ASACO, and Curran, who was very generously shared a video with us on her experience as an ovarian cancer patient who has had radical surgery. So welcome everyone, and thank you so much for joining the panel. Asima, if I could start with you, you have a particularly interesting perspective in that you work in both the UK and India, and indeed you've set up a specialist unit at your hospital in public hospital in India. Can you tell us about your experience in making the case for the need in both countries, really, for women to receive their surgery from specialists at specialist centers?
Thank you, Clara and Francis and everybody on the panel. I think I would want to go back 10 years ago when I was training, and then in Gateshead, one of the centers in the UK. And I think it was that time, perhaps all the evidence was coming up about the role of major surgery and the changes which were happening. So, so when I went back to India in about 2014 or 15, I think a few things which were quite striking is that it's very hard to implement a decision that you, or evidence that you learn from some other place, to be implementing into countries or cultures which are very diverse and very different. And I think while we have thought about evidence generated based on a particular population, age, economic facilities and stuff like that. But then I think one of the things which was very striking, that in a lot of places, the practices are based on the convenience and not necessarily on the evidence. And then it is the convenience which drives the need to push for resources as well, because it's not only about a team, but it's about the time, what wants to invest into that. It's about, I remember reading or displaying Professor DuBois' landmark paper in Kansas in 2009, that classic figure, what is the difference between leaving a centimeter disease and even a zero disease, and then what does it mean in terms of what are the other organs that you need to take out, or the time that is involved, the specialties in the context of a very super specialized setup. And it's quite hard to convince people, but then gradually I think you learn how to do, and you get your results out, and that's how you gradually think. But I think there is an element of health literacy here, because even in the poorest of settings, people would not think twice in the rural setup or in a less than resource setup, I would say, to do a cardiothoracic surgery in a primary setup. You would still have, or people would have a mandate to create a super specialized center to be able to do that, and patients know, everybody knows. But whereas it comes to realizing the change in the practice, that we have to do a different type of surgery now, people still think it's a general gynecological surgery, and it's about making people understand that it is just not 2-3 hour procedure, but it's actually a much more ordeal than that. And I think once you do that, we don't need very hi-fi sophisticated instruments, like it's a surgical skills, techniques, ICU, HDU. If you can do a Whipple's operation, you could do a cytoreductive surgery. It's about that sort of understanding about the resources that you need. And I think it took a little time, but then backed by evidence and your own results, and keep on collecting data, presenting to people and management, and you gradually go there. And I think when you talk about diverse resources, even in the UK, I'm working in the Northeast, it's diverse. I mean, some centres are still struggling with having an NHS theatre time beyond 5 o'clock, where the other centres are struggling to have access to HDU, ITU, and so it's really complex. And I wouldn't say that, except a very few centres in the world, that we have struck the balance yet.
Thank you, and we'll come to that. Professor DuBois, it was your seminal paper, I think, that everyone refers to. Do you want to recap in terms of, just how important is it by way of outcomes that we don't opt for the easiest or most convenient?
Yeah, you're absolutely right. And this paper started a rethinking of the role of surgery in ovarian cancer, and I think we could make very clear that the prognostic impact of a proper surgery, namely taking all visible tumor out, is higher than everything else in ovarian cancer therapy. So the decision about the fate of a patient is mainly made up in the very beginning. So the chance of having a long-term survival or a cure is almost, I would not say completely limited, but mainly limited to the surgical outcome, having a complete resection. And as Dr. Asima said, even leaving small residuals back gets far away from the optimal outcome. Before that, people, physicians and others talked about optimal surgery when they could reduce the tumor up to 2 centimeters or 1 centimeters. And we could make it very clear. And we are currently working on an update, and it's still the same with all the new drugs. Only zero residual disease is associated with a long-term survival and a good prognosis. But then if you have achieved it, the prognosis is really good. We can talk about cure when we add then proper treatment and so on. And we have now in this group of patients, we have now median survival times of far more than 5 years. And it's approaching 100 months even. So it really makes a difference. And
so it's interesting because some might say, we've had quite exciting developments recently in ovarian cancer treatment, but the fact remains that unless you have really good, thorough, expert surgery, that the benefits of those exciting new treatments are going to be lost for you.
Yeah, and we can see especially with the new data we have with the new drugs, with PARP inhibitors and angiogenesis and all that. If you look at the recent analysis of the Paola study, for example, and then you look in the subgroup of patients having a proper and successful and really optimal surgery, these patients are cured. After 5 years, we still have more than 90% without relapse in these patients. So it's the first time we can think about cure of advanced ovarian cancer, but all that is based on a proper surgery.
So there's no coming back from or compensating from lack of.
No, unfortunately not. I mean, we evaluated that very careful in our country, where we had a national evaluation of ovarian cancer surgery and treatment, and we compared patients having an optimal surgery and a non-optimal chemotherapy or systemic treatment, with those having an optimal chemo and a non-optimal surgery, and with patients having both optimal or both suboptimal. And we could clearly show that you cannot replace one by another. So you cannot replace, even with the best systemic treatment, you cannot replace good surgery. The other way around is also true. The best surgery does not allow not giving a good systemic treatment, because you can also not replace or substitute systemic treatment with surgery. So, I mean, it's easy, as it is in life always. you combine optimal modules and you get optimal outcome. I mean, that accounts even when you're baking bread or cooking. I mean, it's every time in life. If you give your children a good childhood and a good education, the chance of a good outcome is better than if you do one thing suboptimal. And that's the same in ovarian cancer. It
Yeah.
is as easy as it sounds.
So we know that nowhere gets this modeled exactly right, but Professor DuBois, are there places that stand out for you that have gotten it more right than others?
Oh yes, that's for sure. I mean, there is a huge heterogeneity in almost every countries I know. I'm part of the quality assurance program in Europe, which we do with ASACO. And so I have insight in many hospitals who apply for being certified as an ovarian cancer hospital, ovarian cancer excellence center. And I can tell you the heterogeneity is bigger than you could imagine. And I mean, especially when we talk about the UK or Germany, I mean, in the UK, to be honest, we have less than 10 centers where they really perform a very good surgery, and the same is true in Germany, and both numbers I just mentioned are optimistic.
Wow.
So, and the same is true in the US. I mean, I know the situation in the US a little bit because we have many cooperations with Mayo and with Memorial Sloan Kettering and with Rob Bristow, and also there is also, let's say, a handful or two handful of centers where you would go, uh, Canada and so on. I mean, it's in every country. And it does not depend only on the money and the resources. I mean, even in rich countries like the UK or Germany or Canada or the US, I mean, the four of the seven richest countries of the world, still there is a huge heterogeneity. And it depends so much on the attitude. If you have somebody there who really is dedicated to it. I mean, ovarian cancer surgery is a painful surgery. It lasts several hours. It costs a lot of blood, sweat, and tears. But if you're dedicated to it and you have a dedicated team, it's never one surgeon, one hero, one cowboy. It's almost always the team, and it's an interprofessional team. You need good scrub nurses. You need good people taking care of these patients after the surgery, and you need other disciplines in some situations as well. So it's a team. It's a team and an infrastructure, but it's not money. It's surely not money, because even in the rich countries, we don't have a homogeneous good quality. It's dedication, it's empathy, and it's motivation. And you have to have people who really dedicate their professional career to it. Ovarian cancer surgery is nothing you can properly do just beside 10,000 other things. I mean, if you are an obstetrician and you do cesareans all day long, and in the evening you go to an ovarian cancer, I mean, this is bullshit. And the same is true when you do general surgery, and you are doing 90% of your time something else, and then do one ovarian cancer. I mean, ovarian cancer for the patient and for the surgeon and the team is like a Formula One race. And if you are a bicyclist, then you would never go to a Formula One race and sit into that car. And the same is true for ovarian cancer. I mean, it's so easy. Ovarian cancer is the most complicated surgery we have in gynecology. It's far beyond everything else we are usually trained in gynecology. And it's also completely different to 90% of what surgeons are trained for. I mean, they are not trained in peritoneal carcinomatosis usually,
Mm.
and they are not trained in the small pelvis. So you have to add both worlds, the surgical world and the gynecological world, and it's the most complicated operation we have in that area. To believe that you can do that after you have spent 90% of your time with something else is ridiculous.
I think, and you've touched on it, and Asima, I'll put this to you. What, and we talked a little bit about it's not just the lone surgeon operating here. It's a team. But what are the hallmarks of a good center? You know, what makes a good center?
What makes a good center? Empathy, dedication, skills, and knowledge. So the most important organ of a good gynecological oncology is brains.
Mhm.
So you have to know what you do. Then you have to train. So it's first, let's say first is heart. You have to have dedication. You have to have some kind of empathy for these patients. I mean, this is you have to spend a lot of energy and effort, as I said, blood, sweat, and tears. So you have to have empathy. Then you have to have brains, and then you have to have skills. And if you combine all that, then you have a good center. I mean, clear, you need resources, but as Asima said, we don't need high-class technology. We don't need Da Vinci's or something you never can afford in countries like India. We need scissor and a little bit of electric power, and more or less that's what we need.
And Asima, would you share that view that you talked about the hallmarks of a good center?
No, I completely agree, and I think it's about a lot of passionate people who actually believe, they're driven by the scientific knowledge that it will work. They're willing to stay back, not being distracted by. It just takes your life, I think, for a lot of people. Suddenly, when you start giving 24 specimens to the pathologist or hours to the intensivist, it takes everybody in a shock when you start doing things. But once everybody starts believing, it's a big team. But as Professor said, I mean, those are possibly the hallmarks of how you start. And as I say, my journey started from being a scientist as well in the PARP inhibitor, and then to the surgery and all. And I know that I have learned from my life that a good biology does not compensate for a bad quality surgery. I mean, no matter, I have seen cells killed with PARP inhibitor, but when I trained I know it doesn't happen. You really need to take the disease out when you can, and then are supported by the good biology or biologics, then you get an optimal result.
Thank you. And I'm going to come. Oh, go ahead, Professor.
Yeah, it's not so easy to recognize a good center easily. There is no plate on the door saying this is really a good center. I mean, the majority of plates are not worth the metal they are printed on. So it's not easy. I mean, you have some hints, let's say, some ideas. The first idea is, does this center participate in surgical trials and trials in gynecological oncology? This is a very strong indicator that there are people, that there is a team who is passionate for it. So the second is numbers. Numbers does not substitute for quality. I mean, you can do things frequently wrong, but on the other hand, if you want to become better, you need numbers to train. So numbers is a prerequisite, but it's not sufficient enough.
And I'm going to come back to this, but I'm mindful of time. And Charo, I wanted to come to the patient perspective on this because it's so important. And your experience in Spain has been one where you have concerns about the number of women who have access to specialist gynecological oncologists. Can you tell us a bit about that? What's happening in Spain and how you're trying to respond to that?
Yes, Clara. Well, thank you very much for inviting us to be here. And in Spain, and not only in Spain, the problem is that there is not required to be a gynecologic oncologist to carry out a surgery like this, an ovarian cancer surgery. So there are, as Professor DuBois said, there are general gynecologists that dare to undertake surgery for ovarian cancer, or even surgeons that may be very good, but they are not specialized, or they are not used or dedicated to ovarian cancer. So this is a very, very huge problem, because it leads to situations like, for example, a patient is said that, well, is diagnosed with ovarian cancer, and they tell her that there's no possibility of surgery in a certain hospital, and she goes for a second opinion, and the opinion is the same, no opportunity for surgery. But well, a member of her family tries to find out, and finally she finds a hospital where the patient has her surgery, and it is real, it is a real case. And now at this moment, she is carrying out life with good quality, and she is in treatment after a good surgery. So this is a very, because sometimes when we meet together the different associations in Europe, we know that this happens in quite a lot of countries. And it is, well, they always say, well, the patient must be empowered. But this is not the solution, because a patient may be empowered after she has been living with her disease for some time. But when you are given the diagnosis, maybe that, except for cases that you have this illness appears in your family, or you are carrying a mutated gene, etc., many times you have no idea of what ovarian cancer is. So that, and you have the right to be confident in your doctors. So if your doctor tells you, I'm going to operate you in 10 days, you don't have to doubt about his or her skill. You think that you are in good hands, and you go on. So it is a problem that, well, both doctors have explained it perfectly well. It is a question that doctors that are not prepared, that have not the skill for or to carry out or to do an ovarian cancer surgery, should or must refer their patients to a center. Because, for example, in Spain, there are very good centers, and,
Yes.
and moreover, in Spain, we have very good public health service. And we know that, but this is one thing, and the other thing is that you can reach them because you have the knowledge. So this is the problem we face many, many times. And of course, really, ovarian cancer prognosis is a question of luck in many cases.
Yes.
And this is unfair.
Thank you for that, and we'll come back. I'm really keen that we share Caroline's video, actually, because it's a perspective of a patient, and Caroline and Asima know each other very well, but thank you both for sharing your experience. So if we could see the video, and then we'll come back.
Hi there, I'm Caroline, and I'm 44 years old, and I live in a beautiful but remote part of England in a county called Northumberland. And it was back last year in July of 2020 when I went to the doctors and complaining of quite a severely bloated tummy. And I was diagnosed within 3 days of having ovarian cancer. I was stage 4B, and the program on the pathway was set relatively quickly. And within 2 weeks, I had a surgery date and chemo options already put in place. We went into surgery knowing that it was going to be a feast or famine situation. It was either going to be that the whole surgery was going to take place, or none of the surgery was going to take place, and we'd have to do the other option of chemo first to reduce the size of the tumours. When I did wake up, I was in intensive care. I had 15 and a half hours of surgery. And in that surgery, they had taken 44 biopsies from 25 sites around my abdomen. And the feeling that I got when I woke up from the surgery in intensive care, and my surgeon was holding my hand, and I remember it being the best feeling in the world. It was probably the best day of my life when I woke up and felt her hand holding mine, saying to me she'd got all the sites. And it was even better to some degree than what my wedding day was and my children being born, because I'd been given a new lease of life. And she was delighted, she was relieved, and I could see it on her face just as much, because we both realised the enormity of the surgery that I'd had, because having 15-hour surgery is not something that's easily given by the executives and the powers that be, and for it to actually work as well, you know, is absolutely amazing. And I knew that enormity when I woke up, and I knew that in the days after when I was coming through my recovery. And it makes you want to get better. It makes you want to do everything you can, because you know what that means to be given that opportunity to have that surgery.
Thank you so much. I'm just really struck by that account. And thank you, Caroline. Thank you so much. And Asima, I know you have a strong view about the need for surgeons to have those conversations with their patients about surgery and decide what's best for them. And do you want to just say, if we have about 5 minutes left, and I'll come back to everyone, but do you want to just say a few words about, you know, that critical relationship between the surgeon and the patient and decisions?
Yeah, I mean, I think, you know, I'm learning too over the years, and I think I see a lot of more younger patients in India. I think the median age of ovarian cancer is 52. In a new center that I have starting working, it's 42. Caroline is 44. So I know that the needs of the patients, they sometimes have small kids, they have different expectations of their endpoints, and it's mostly they want to live longer for a lot of reasons, and then the quality of life comes in. So whereas it's a bit different when you have the other side of the age. But then I think it's sometimes a very difficult decision to really not be judgmental about it, putting the facts, what is that, but also be sensitive to what they really want, and then making that call. And it requires time to build up that relation, to have a talk, not also having a talk with the other members of the team, the different sides of the story. So it's not easy at all. As Caroline said, I mean, it took quite a long time. A lot of these surgeries take a long time, you know, anesthesia even longer. I mean, but then to be able to be willing to go through that with an expectation that it may or may not work. A lot of ladies ask me even this morning, that what would you do if you were the patient? And I sometimes struggle myself, because, you know, I know these are women of my age, maybe some younger, but different perspectives, and it's very hard. But at the end of the day, people have strong wishes and preferences, and then we should respect that into our matrix of decision making.
Thank you. But it comes back to, and this is the theme that comes in all of these sessions, it's about time, the time to enable people to have relationships. And so everything is, you know, we want things to move at a fast pace, but the decisions are so critical, just ensuring that there's, you know, time to absorb and process. Professor DuBois, I cut you off earlier, so I'm going to come back and start with you in terms of kind of final reflections on the conversation and the issues that have come up.
Yeah, I mean, it's a very intense relationship what you have with the patient and the surgeon. So coming back to that, having a many hour surgery, and I mean the average duration of surgery in our team is almost 7 hours. It's 6.5 or so hours, the average. That means you spend so many time for just one patient. So this is a very personal relationship you have, and yeah, I mean, I can't describe it very well, but it's always a very personal relationship, and always, I mean, me as a surgeon, uh, it's such a big thing of trust that a patient allows me to go into her abdomen. I mean, I do something that in other cases you would get to jail for that. And so I feel so this is a lot of dignity, and it's a lot of trust, and it's a lot of, I mean, it's such a privilege to that somebody allows you to go into your body. Yeah. On the other hand, it's a lot of trust that then if you allow somebody to do that, that it's no doubt that you really give your best. And if you're not able to give your best, then to say, no, I'm not the right person for that. So I mean, usually it should be a better world. So and it's not. So we must help women to find the right places, to find the right persons. We should help physicians to be educated and to develop an attitude to that they want to take care of these patients, and we should enable patients to make the right choice. I mean, as Charo said, it's not easy, and just having a second opinion does not solve anything. I mean, ask two fools and you get two foolish answers. I mean, the question begins with the question, who is the right one for the second opinion? So
I see lots of
it's
nodding. Lots
yeah,
of nodding.
but it's, I mean, this it starts with it. On the other hand, many patients do not even ask for a second opinion. I mean, usually a family, when they decide to buy a new washing machine, they read tests and ask at least their neighbors and their relatives, and they look for 2 or 3 models before they spend, let's say, a few $100. When it comes to ovarian cancer, many patients do not even ask one question. They just go to the next hospital and say, here I am, do whatever you want. And so we have to work on both sides. We have to work
Yes.
with the patients and the women, so the women's of the world, to get knowledge that if something like this happens, then just have a break, not do the next best, but just start thinking, calling patient advocacy groups, calling patients in initiatives, and just go to Google and try to get some information.
Thank
I
you.
mean, very rarely, cancer is an emergency that you have to act soon. There is no worsening of prognosis if you take 1, you take 2, you take 3, and even you take 4 weeks to do the right thing. This time is really a good investment.
Thank
So
you.
you have the time. So, and then ask, and I think patient advocacy groups and patient initiatives are excellent addresses.
Totally. And I wanted
that.
to give Charo just a sort of 30 seconds. We're really right up against we're over time and right up against, but Charo, that really speaks to what you do, isn't it, in terms of empowerment and information?
Yes, that's it. We try to help. Well, all of us are patients or have been or are patient, ovarian cancer survivors. And we know the difficulties and the shock you get that takes you away of reality. In fact, you want to trust your doctors, that's it. But yes, so we know I was very lucky. I was in very good hands, but it was luck. it was luck. I cannot say I did anything. It was God, I suppose. That so it is very important, and it is very important that, for example, I know that it is very difficult to change things through the central administrations, but perhaps it would be easy or easier and to get some results through medical societies, so that they make their members aware that they cannot touch ovarian cancer surgery if they have not the skill. You
Yes.
know,
We
I
have,
think that it would be.
I'm going to,
excuse
we
me,
have some,
just one remark.
yeah,
In Europe, at least, we have the ASACO, our European Society of Gynecological Oncology, identifies centers who are dedicated to ovarian cancer. And we have 17 centers of excellence identified all over Europe. And this is a first step.
it is. So
Yes.
I'm right at that point. We could carry on, and I'd love to, and we might bring you all back and do just that. But I wanted to just thank you all so much for your thoughtful contribution. Caroline, thank you for sharing your experience and being here with us today. We just really value it, and to all of you. So, so we're going to draw a line there. Our final session today is on clinical trials, and Francis Reed again is leading this discussion. And I think you just hit on the next session on the platform panel, and it will take you there. But but just again, thank you so much to this amazing panel and for such an excellent discussion.